Well, good morning, everybody, and it's a pleasure to be here, and thank you, Michael, for inviting us back. In fact, what's interesting, this presentation that we're going to give you is actually 6 years in the making. And believe it or not, there's 4 more years of it to go. This is a 10-year project that Christine will have invested her entire career as one project, if you can imagine that. But we're here to focus on the first part of the project that we finished, which was the major part of our clinical pathology renovation and relocation. We have many other phases, and similar to the Texas Children's presentation yesterday that I saw, you'll see some common themes in here regarding lean facility design. But part of the focus and reason for coming back was not to repeat the presentation, but to actually talk about lessons learned. And at the end of the day, all the things that we go through when it comes to project, it doesn't make any difference if there's not tangible outcomes and business benefits that you set to achieve in the first place. And that's what we're here to share with you, those successes. So a little bit about myself. My name is Bob Harris. I'm the Executive Director of Facilities and Associate Hospital Director and Corporate Officer for the University of Michigan. And a couple of fun facts for everybody. The University of Michigan brand is one of the most recognized brands globally, and it's also one of the oldest, founded in 1817. And we are the oldest academic medical center in the United States, founded in 1848. And for those of you that either are physicians, married to physicians, have inspiring physicians, in 1948, the cost of medical school was $5 a year. Fascinating statistic. University of Michigan is leaders in best and have created numerous clinical programs and inventions, the EKG, the first dermatology program, the first burn clinic, and many other firsts. But being leaders in best isn't always best, because as a result, you have people that have a mindset that oftentimes they think that what they're doing is indeed the best, and it's difficult often to get those people to change. And so one of the things we're going to talk about is the journey of lean facility design on this specific project. And again, some of those lessons learned. And much of this is about having the users come to the conclusion and realizing they don't know what they don't know. And it's about getting people to actually understand the challenges, and recognizing those gaps is a part of this. So this is our journey. Lean facility design, this is our agenda, pathology outcomes and lessons learned. Why does it matter, okay? So at the end of the day, traditional design, from my experience, and I've been in this business for 37 years, which is hard to comprehend, oftentimes you'll sit down with a customer and they'll say, here's what we need. And they don't tell you what the business needs are. They tell you the number of exam rooms, triage rooms, and operating rooms, actually independent of what the business plan is. So oftentimes, the traditional process doesn't get us to what we want. And how often have you heard us say, that's not what I wanted or I asked for? Even though they've signed off on documents and signed off on drawings and went through all these processes, oftentimes we hear that. So lean facility design achieves, from our point of view, the most efficient, innovative, and flexible spaces, and it drives design from process flow. Again, you'll see a term that we use here a little bit in the presentation. Builds positive trends in lean work. At the end of the day, if everybody remembers, lean is the origination of the Toyota method. It's really down to one thing. It's about eliminating waste. So quickly in the beginning, lean has been operationally involved with the University of Michigan now for the better part of a decade. In the so there you go, I'm going back to the university, to the old days. In 2012, we actually were charged as a facilities group to incorporate, instead of after constructing projects, going through lean operational optimization and saying that's not what we wanted and come back to revise it, to implement new lean facility design parameters. So we set out to learn what lean was. At the time, from a facilities perspective, it was a novel concept. And what we've learned from the site visits, and we visited Virginia Mason and Seattle Children's, and we spoke with a couple of the folks here from that area, lean is a mindset, and it's not just a process. Form follows function. When we say what are the advantages of what is lean, it's eliminating waste and form following function. And form is defined as the building, and the function are the clinical, patient care, and all the processes to support that. Improvements are measured in steps, literally. Standardization is critical whenever possible. I can't emphasize this enough, especially for your larger healthcare systems that have distributed networks and systems, especially on the ambulatory care side. Standardization of work, standardization of actual processes, standardization of rooms whenever and wherever possible is absolutely critical to eliminate errors. which obviously impact the outpatient's outcomes. Significantly reduces construction change orders. We've heard about that. We use lean, and we use a benchmark that we are going to reduce the building by a minimum of 20% from an initial benchmark. That is actually a measurable goal that we actually work towards, and business goals are exceeded. So we started with small projects, and we worked up through 4 projects. The Child Adolescent Psychiatric Hospital, I won't go into details about these. Some of these pictures on the left you can see here are actually of the Pathology Project. We actually worked up a little bit larger scale project through our Emergency Critical Care Center. This was an emergency department project, which is almost a ICU OR type setting to keep people out of the inpatient rooms if and where possible. It really was a breakthrough in technology and application for clinical care. We expanded and squeezed yet 4 more operating rooms within our university hospital, which is hard to comprehend for how tight we are. And then the pathology renovation and relocation, which is what we're going to talk about. You'll see the note at the bottom there from the clinical inpatient tower. For those of you that follow us at all, we just recently approved a $920 million inpatient tower expansion with 264 beds, 20 operating rooms, 3 interventional radiology suites. And that lean process involved 850 people and tens of thousands of hours of combined man work of time through the session. So that's part of our journey here. I'm going to go through these fairly quickly because a lot of you have heard about lean, but lean from the University of Michigan perspective falls into 3 categories in terms of our toolboxes. You can see the conceptual design, schematic design, and design development. And what you'll find is each health system and each consultants that we've come across sometimes intermixes some of these things. Some people may have mock-ups in the conceptual design. We do not do that. We actually wait towards schematic design, and there's purposes and reasons behind that, things that we've learned. But we also have the advantage of a lot of other academic and powerful tools that we have that most other systems do not have. So those are our toolboxes that we typically use. Again, a lot of you have seen these. These are the current state value maps. I can't stress to you how important it is to sit down with your staff and let's say, I know what we want. I know what my work is. But taking the time with an experienced lean facility design facilitator asking questions and documenting that is an eye-opening experience if you've not been through it. So this is a really fundamental component to get down to, for starting. It's really to outline what are you doing as of today. Multi-day workshops, again, you've seen all this. Involves a lot of cross-sectional departments. We have frontline staff. We have people from the janitors to the housekeepers, to those that are delivering food. All these people are involved as it relates to our multi-day workshops. Cross-functional teams, and so we don't basically set the environmental services group at one table, we don't take the food and nutrition at the other, and everybody comes on up. We take someone from each team, from each department, and we have multiple tables working on our existing and future state mapping as it relates to for cross-departmental pollination. So very, very important. Paper dowels, you've seen all this before, so I'm going to skip through this. But again, paper dowels are very important because it's the first time, and the paper dowels and the square footages of the departments which start to emerge after your existing state and part of your future state are the first tangible pieces of paper, literally and figuratively, of what your department gets to say, how much space am I allotted, or do I need based on my business parameters? So a very popular exercise that we do. Spaghetti charts. This is where we say we literally measure in steps. Some of the projects that we referred to earlier in the presentation in terms of the Pathology Project for the children's adolescent, we were actually had the design, we were bid. Construction documents were done, we were bid, and there was this desperate plea of saying, can you re-look at these set of documents one more time, but take lean principles, and we said, we're done. So we took a pause and we sat down with the groups. In less than 2 weeks, we documented existing state and future state, and with spaghetti diagrams. We didn't have time for mock-ups, unfortunately. But even those steps alone completely rearranged the layout of the facility and the project. We repackaged it and rebid it, and in most cases, the reduction of actual physical steps from our staff was 50 to 75%. And again, it was only because we took the time to sit down to actually have them, each one, map out their work processes and flows from the point of a patient leaving their home to the point where they come through our facility and leave, and all the individual flows, we go through this exact same process, of which I'm sure many of you do too. This is a very powerful tool that many of you probably have seen before. So this is one of the advantages of working at the University of Michigan. We have some of the most powerful and leading edge technology in the United States. We have what we call the cave. It is 3D reality, and this is not like sitting at home, folks. We actually can model entire hospitals and facilities. We did for our Pathology Project, all 160,000 square feet of that, we actually plugged into the cave, and you walk yourself through, and I kid you not, if you walk into an elevator shaft or through a stair, you feel like you're falling. Everything is in spatial relationships. Heights and colors are all there. This is an incredibly powerful tool. This is not looking at a 3D model on a screen. This is you literally immersing yourself within the facility, and with the joystick, you literally traverse. You go upstairs, you go downstairs, and you walk your way through. And this is one of our very early steps that we do before mock-ups, and there's a number of reasons we do it that way. It's because once we document existing state and then we talk about future state, we want to actually start sketching together concepts that people can feel, because we find if we start mocking up just concepts, where the mock-ups change much more frequently and often. So we use this as a starting point of which we then mock up. And then we bring people in, and even then, there's still changes, of which you'll see here shortly. Mock-ups, again, we've talked about that a little bit. You've seen a lot of these. I'm sure most of your health systems are doing this. We use a combination of cardboard, plywood, and other materials. So we tend to use plywood and heavier objects where there are things such as columns, which are monuments, things that they can't move. We don't want the staff to move them into the field. And where we have other products like walls and other components that are non-monuments, non-shafts, non-structural components, we actually make them out of cardboard. Because at the end of the day, you can't go through a mock-up, and I promise you, you're going to go through your mock-ups, you're going to have the staff visit, and when they start to simulate, they're going to want to make changes. And you can't send everybody home to say, well, let's document your changes. We're going to bring in a crew tonight to modify it, and then bring you back from your work tomorrow. It's an incredible time and commitment for our care providers to do that. It's an incredible commitment to the institution. These investments for a large-scale project run in the millions of dollars as it relates to labor, as it relates to doing that. But at the end of the day, people tend to forget that building buildings is only 10% approximately of the life cycle cost of the facility. So when the University of Michigan Health System approved the $920 million, which was $1 billion, so let's just call it $1 billion for round numbers, we're making a $9.2 to $10 billion commitment over the next 50 years. Spending a few $1 million now is money well paid. I can promise you that. So what have we learned from our own projects? And this is a picture of some of our lean facility teams. We use technology to aid in our design process. I talked a bit about that. We capture current state, mock-up activities and virtual mock-ups, tests, retests, fail. You can't go through this enough times, folks. I can promise you that. And create teams who can actually lead that. We tend to lead all of our processes in-house. We have all of our own trained folks. We even have an architect that's the mock-up man. And when he's on the site where we're doing mock-ups, if we can't move something or something needs to be fabricated, he fabricates it on site. So having design professionals embedded as a part of the overall mock-up process is incredibly powerful, and we've learned. Facilitate large group sessions and develop your lean focused project plans. Video capture. So this is going to be an existing state, correct?
Yes.
This is an existing state and part of the pathology. And so again, it's one thing to sit down to talk about people to walk through their existing state. It's another to spy on them. Now granted, this was with a GoPro. Everybody knew about that. And this is a time-lapse video so that we can actually see workflow. And that more importantly, those that were doing the workflow of what it was like. Go ahead.
So this is our front window for the specimen processing drop-off area. And what you'll see is that at various times the front window fills up and then empties out. And we were also spending a lot of time watching the traffic flow around the workstations in the middle, so that when we did this in design and when we were looking forward to our future state, we tried to eliminate a lot of the common walk paths so that people were less congested in their work. Plus, we put some fun music in, and then they love to show it off to their friends and family and say, this is what we do.
Yeah, exactly. And you'll notice where the specimen drop off, there's a lot of containers that can continue to come up into the bottom of your screen. And again, they became congestion points and things that we addressed during the project itself. Okay, we'll go ahead and skip forward. This is the last video we have. Now this is a mock-up of remind me what this is.
This is actually the specimen processing mock-up, but we combined the specimen processing group with 3 other groups in the future state, which was part of our goals of combining groups that do similar functions. But the upper corner of the screen here is where the specimen processing area is, and then there's some other labs in the other areas. And this will run for a couple minutes, and you'll see during an 8-hour session the changes that happen. Especially watch on the left side of the screen, we did a whole scale change of that area during the day.
Yeah, and just for the purposes of time, we may just want to run it for about 1 minute. So this is the future of the space that we saw just a moment ago. And what I want you to pay attention to is the volume of people and what will ultimately become a radical redesign. This was already ran through the cave. Everybody thought that they knew what they wanted. And you're going to see significant changes. It's just incredible. And again, this is a fantastic example to where we brought 3 groups together working on similar processes, separated by many miles in different facilities, coming together with shared resources and very similar tools, and through all the existing state and future state, and in addition to the simulations, everyone was convinced that what they wanted. And when you sit down and actually, look at this, it's incredible the amount of change. This was elapsed over an entire day, but that just goes to show you the time commitment. All those folks are all being paid. They're all giving up their patient care duties, and they're all being covered by other staff, but these are the folks that are doing the actual work. And again, it shows you the powerful, and what if we didn't do this?
This is running backwards now, kind of resetting it to where it was in the beginning. And many of these things are things that are ducted so that they are monuments that we would not be able to move later.
So, yes. Great, thanks.
All right, we'll move back to the presentation now.
Again, take a quick look at the before and after. A complete redesign. So Texas Children's actually presented and talked a bit about this yesterday, about getting it right the first time. And I can assure you, when we're done, what we're going to build won't be perfect, but it'll be a whole lot more perfect than what we thought we would have built if we hadn't gone through that process. Christine?
All right, so I'll talk quickly through some of the pathology relocation and renovation projects. I'm mainly going to talk about phase 1, where we moved our non-stat labs off-site from the hospital. We're right in the middle now of construction on phase 2, which is renovating the spaces within the hospital for more urgent labs.
And as a reminder, this is clinical pathology. This is not our research arm, which is a separate section.
So the first example I'm going to use is the microbiology lab. The microbiology lab performs a lot of testing around infectious diseases. They take specimens of all kinds, a lot of fluids into this lab. They were in our hospital before the move, and they had a lot of structural monuments, a lot of hoods, columns, walls, casework that was not able to be moved or shifted. And so their focus was not only in incorporating an automation line into their future state, but in also making a more flexible, open space and bringing 2 teams together that were in 2 different buildings. So this is what their space looked like before. Lots of structures, lots of walls, lots of built-in casework. The end, as we moved them in the summer of 2018, they activated an automation line, which automated many of the manual functions that they were doing in the past. They combined the two labs that were in separate spaces and put them all together into one. And then they have a very flexible open space that they're able to rearrange as technology changes for this lab. We did some surveys after the fact. We found that the co-location of these two labs, there was not only a physical separation, but there was really an emotional separation between the two sections of the lab, and to bring them together increased the collaboration and teamwork. It cut down on transport of specimens back and forth between the two groups, and really created a more holistic collaborative group. The next example will be the molecular laboratories. We had 6 different laboratories all doing molecular work. They work with DNA, and there's a lot of cancer diagnosis that they're doing, but also inherited diseases, tissue typing, and non-infectious diseases that they work on within this laboratory. And the focus for this group was taking these 6 different, very unique and very separate labs that all do similar things and bringing them together into one. We call it the molecular complex. There's a lot of airflow requirements around some of these tests, so we do have some walls around some of the spaces, but when possible, we combined the processes together of those that do similar work. This involved not only a lot of mocking up and thinking through different equipment that they could potentially share, but also a lot of team building that we needed to incorporate into this design process, because it was really 6 different cultures that we had to bring together to work in their future state. And at the end of the day, as we move them in, they are finding a lot of ways to work together. They are sharing one big step of their process is extracting DNA from the samples that come in. They used to all do that separately. Now one group does that for all. And I won't belabor all of these points, but every couple months they're coming out with new ways to work together, to collaborate, to share instrumentation, and to really move the field of molecular diagnostics further. The faculty office suite was a very interesting design process to move through. We had a champion, one of our very senior faculty members, that wanted to not replicate what we had in our existing state, but to make a more collaborative, innovative space for our faculty to work in. The faculty office was their home for everything. They do their diagnostic work there. They look at use their microscopes to look at slides. They have meetings. They teach. They coach. And we started to say, how many of those things could you do in other places to invite more collaboration among your colleagues? So through a very long process where we not only mocked things up, we actually built a prototype and moved them in for 3 to 5 weeks at a time and gathered their feedback. We incorporated 172 pieces of feedback from that experience into their final state. And their ultimate design has 7 neighborhoods spread across one large faculty suite. Each neighborhood has collaboration spaces and somewhat smaller of their personal space, but they gained a lot of collaboration space team areas rather than having their office be the focal point of all of their activity throughout the day. And we're seeing gains in innovation and gains of the ways that they're able to connect with colleagues that they had never worked with before. And here's a little bit of the faculty feedback that we're hearing. We not only allowed them to tailor and customize their office, but then we allowed them to work with their colleagues in their neighborhoods and customize the spaces that they'd be collaborating in outside of their offices. And these are some of the pictures of those unique collaboration spaces and the integration of technology that we used into those work areas. And one final example is the clinical flow laboratory. After we moved and we had everybody happy and settled in the new space, one of our medical directors said, we need to move one more group.
Brand new building.
We had not yet been there 6 months when this initiative started. And because we had built this space with a lot of flexibility and used flexible lab benching, and we were able to move utilities and ceiling panels and rearrange lab benching, we were able to move an entire other lab group out into our space less than a year after we had moved in. And we really viewed it as a success, not only in the team coming together and shaping their workflow around this new space, but in the facility being able to support such a substantial change so quickly after we moved in.
We've heard talk about flexibility in the past. Avoid monuments at all costs. This is a fantastic example. Through all the things that we did, they still thought after the fact, an aha moment. And tied to the presentation that we saw yesterday about where technology will be, this space will be adapting and changing in a few more years. So the more flexible you can provide, flexibility both in furniture and products that you select and design layouts, the better off your institution will be.
And this group actually begged for mock-ups. They wanted to mock up the space before we were able to build it, and time didn't allow us to do it, but it showed the cultural shift and that they were coming to us and begging for mock-ups in the design process so they could really envision the space. We did use paper dolls and spaghetti charting, though, as we did their redesign. We're also going to share a couple lessons learned, and some of these are from the activation process itself. As we moved groups out throughout the summer of 2018, we knew that change would be difficult and we knew that it would be a struggle, but we had no idea the extent of that.
Folks, I can't urge to you, in fact, we had a great presentation yesterday, I think it was, again, Texas Children's, and they talked about many of the similar themes, the mock-ups and simulations and things. At the end of the day, even then, you have to prepare folks for the cultural change. People may ask and want change, but when it actually comes down to the rubber hits the road and they have to work there, it's very difficult. So one of our takeaways on this to share with you is to make sure that your work process modifications, if you can get them implemented before you physically make the move, or you simulate that well in advance of the actual move, is unbelievably critical. No matter how perfect the space is, it still has a human element to it. This was a major, major learning curve for us.
I think even parking in a new spot, having a new walk route, having a new atmosphere surrounding you is a lot of change. But then if you're also going to change the structure of your day, that added to that change. And our quote for the summer is that everyone has a meltdown. And it just seemed that throughout the summer, as 500 people were moving into this new site, at some point or another, everyone had a meltdown.
Yeah.
So it's some lessons learned that we're going to take into phase 2. Another great lessons learned, we call it Leaders Emerge. We spent a lot of time thinking about how to structure our activation. And what we ended up doing was having a lead within every group that was moving. And to make it fun, we called them move captains, and we had lots of symbolism around the move captain. But that tended to be somebody more junior within their department that had some communication skills and some potential leadership skills that we wanted to foster. And we're seeing the benefits of that pay off now. Of course, it was a benefit to us during the move because somebody within that unit was tracking the task, keeping on top of things, and was part of the unit that was moving. But now we're seeing some of those move captains being promoted into supervisory or managerial roles now, and it's really wonderful to see that the project played a role in moving up the next generation of leaders within the pathology department. And our final lesson learned is no problem is a problem. If people were being fairly quiet, maybe there was a group off in the corner at a meeting that wasn't saying a whole lot, it was interesting that a month or two later that would emerge as that group was having an issue or a problem or some infighting or something that we needed to address, sometimes on an emotional level to help them get to a point where they were ready to move. So as the project team working on the activation now of phase 2, we're being very careful to really check in with each group moving, and if we're not hearing from a group at all, to assume that there's a problem and to engage with them more directly.
Is that the last slide? Mm-hmm. So a couple of key takeaways on this. So first of all, thank you, Michael, for having us come back, and thank you, all of you, for your time this morning. We're really passionate about this, and it's interesting because culturally this was a big deal for us to get leaders and best to say there's potentially a better way of doing things, and believe me, that's not easy. But the realities are, now that we've implemented this, to Christine's point, we actually have departments coming by and starting to complain if they do not get to go through the whole process because they've seen the value add to that. But again, the takeaways of this are through the traditional lean toolboxes, do all your existing state, future state. Do not underestimate the cultural change aspects that's involved with implementing these projects. Simulate, fail, and refail. Make sure you build plenty of flexibilities. And in the end of the day, we heard so much about technology and IT, but it's still about people. And healthcare ultimately is about people touching other people and making decisions with that information. And this process will help implement that and help create the ideal patient care experience and the outcomes that all of you and we expect as citizens of the United States to expect when we go to the hospital. Thanks for your time.